Uh, Hi, everyone. It's a pleasure for me to be back here in Paris. I'm very excited to see this kind of audience. There's so much dynamism in the city around healthcare entrepreneurship. So I was asked to talk a little bit about my personal experience, but also the story of my startup, Rubicon MD, which I started about a year and a half ago. My background is as a physician. I'm a specialist. I'm a nephrologist. And it's been a really challenging decision to make to somewhat leave medicine to jump into a world that is somewhat different from what I've spent many, many years training for. And I think it's something that many of you would recognize. In fact, I'd be curious to know who here is a physician or a clinician? Okay. Who is a clinician entrepreneur? Besides Ronnie and Cecile, okay. We're starting to see a kind of a huge number of physicians, medical students who are going into entrepreneurship in the US, and it's starting to happen in France, it seems like. So I'd like to share some of these experiences. I'd like to do it in the context of ecosystems and culture. There's a culture to medicine, and there's a culture to entrepreneurship. And being able to merge these and understand what you bring as a clinician is extremely important to starting your own venture. Before I start, I'll tell you, a lot of people ask us why we chose the name Rubicon. So the Rubicon is a river north of Rome, and Julius Caesar, who had conquered what is now France, was very popular amongst Romans, and he was a threat to the Senate. And so there was a law saying that you were not allowed to cross the Rubicon with an army. And Julius Caesar, being Julius Caesar, thought about it a second and said, I'm going to cross. And so this was the beginning of civil war and the beginning of Western civilization from that point. So when people talk about crossing the Rubicon, it means the point of no return. The die has been cast, and that's how we feel about healthcare these days. It's a very interesting time to be revolutionary about how you approach things. So a lot of medical students, residents, fellows, even attendings come to me and ask me, what does it take to do a startup? Do I have entrepreneurial DNA? I just have an idea, but I'm a little bit scared about starting this. The point of this talk is to show you that there are a lot of parallels between being a physician, training as a physician, and being an entrepreneur. And I'll talk about a few things like code switching and culture. So this is my DNA, courtesy of 23andMe. Actually, it's not really my DNA, it's my ancestry. But interestingly, I think of it more as a cultural fingerprint. I think that it's extremely important to understand the culture you're in, whether it's rich, how deep it is, because entrepreneurship is about bricolage, right? It's about taking one thing in one culture and mixing it with something else and create something new and doing multiple attempts at that. And so I point this to you because I knew my story. I knew that I left Vietnam with my parents after the war and moved to France and spent some years here, and then moved to the US to study. But a year ago when I took 23andMe, I realized that I actually had some Native American blood in me. So I thought it was kind of interesting that here form follows function. I left the map of France intentionally blank, not because nothing happened when I lived here for about 15 years or so, but because I had a wonderful childhood. And a lot of people say that entrepreneurship starts after a time of crisis. And crisis is what happened after those 15 years when I moved to the US. And so it was a major culture shock. And I will tell you a little bit about the training of a physician through my own kind of CV. But I'd like you to make parallels about this medical training with your experience as an entrepreneur and tell me whether there are major differences or not. So I trained as a medical student at the University of Washington, and as a typical medical student, very idealistic. I wanted to change the world, very passionate about healthcare. And this is really your idea stage, right? This is where you have this idea, you want to have a major impact, but you don't have the skill sets or the network to do anything about that. And very quickly, you learn through residency. As an intern, when you spend 90 hours a week or 100 hours a week working on patients, you think that it's about your training during that stage, but it's really not about your training. It's about empathy. It's about you realizing that what you're doing and what you've trained for so far is really to take better care of the patient. In the world of entrepreneurship, what this is the kind of patient-centric or customer-centric view, right? It's also during that time that you learn to be resilient, and you just learn things and realize that there's a lot more to learn. You're running around with your head on fire, trying to plug holes, and you learn to prioritize the same way as an early stage entrepreneur is doing. But what is slightly different in the training for medicine compared to entrepreneurship is you also learn to structure things. You learn the way you want to present a case to your attending, to a resident, to another specialist. That's the messaging. That's how you learn how to pitch. It's a different type of pitching, but that can be adapted when you start switching into entrepreneurship. You also learn that sometimes when things fail, whether it's an organ, whether it's you've misdiagnosed something, whether the treatment you've given doesn't work, or whether the patient dies, sometimes you learn about futility. And it's an important skill, I think, in entrepreneurship to know when to stop and when to shift gears or pivot. And then I went on to a fellowship, and so I think of, first of all, I think of residency as the MVP phase, right? You're continuously iterating on the same process, failing quickly, et cetera, et cetera. And then in fellowship, what you learn is to hone your skills, to kind of fine-tune your knowledge. You become somewhat of a consultant, even though there's much, much more to learn. But now, general practitioners or residents and fellows talk to you because you own a certain expertise. It's also an interesting phase, I think, because it's a phase where you somewhat brand yourself. You start gaining a reputation. You've gone through your MVP stage, and now you are in a stage where you've figured out the quote-unquote market or your specialty, and you're fine-tuning that specialty to make your product or yourself or what you know slightly better. It's during this stage that I realized that I was very entrepreneurial. In fellowship, typically in the US, what happens is you spend maybe 1 or 2 years of clinical training, but you also spend a significant amount of time doing research. And it was doing research that I realized that I wasn't interested in incremental innovation. I wasn't interested in taking a database, looking at it from a different angle and crank out some data. I really wanted to do something that was unique. I wanted to be the first at doing it. And a lot of the projects that I started there kind of followed that trend. And it wasn't very short after that I met folks at MIT who ran something called Hacking Medicine. This was about 4 years ago. And I was curious to know what happened during those startup weekend events. And so I went, and I was completely sold on this idea that you can bring people from different industries, different cultures, put them together in a room for 2 days, set some time constraints, some resource constraints, and see what happens. And as a physician who really was intimidated by that because I had clinical knowledge, but I don't know how to code. Nor am I a designer. But it was interesting that by working together with these people, you're really able to build something that's interesting. You're building teams, but you may be building slight products that can go on to become startups. And so I took, so the story kind of splits here, because I took this concept of the hackathon and wanted to bring it into my hospital. I created this platform called Reno, which I'll talk to you a little bit about afterwards. But it's out of a hackathon about a year and a half ago that my company, Rubicon MD, came out of. And I will talk to you first about Rubicon MD. But code switching is this social cultural notion that you are able to move between one language or one culture to another language or another culture based on the context. Here's an example. All right, so this is just to illustrate that you may act a certain way. Maybe in academia, you're maybe a little bit more, square, straight shooter, wanted to get promotion. But in entrepreneurship, you meet people who are exciting like this, and you act very differently. And I encourage everyone to do that. Go out of your comfort zone, right? And if you're a physician who is used to doing research, et cetera, go out and go to, workspaces. I met somebody who created La Paillasse yesterday, and it's such an exciting community. Things like that are where you engender innovation. Rubicon MD came out of a very vibrant ecosystem in Boston, and I'm putting this, and I'm seeing people kind of drool and be excited, because if you're an ecosystem entrepreneur, you want to create connections here, right? You want to connect the dots, and that's kind of how I think as well. This is unfortunately not any solution. The solution is extremely complicated. Maybe there's no solution on how to connect different ecosystems, different cultures to build startups. But I think it's important to think about these things as you are creating communities for your entrepreneurs, and engage physicians, because they are evolving very, very quick. They're realizing that technology is moving ahead. Care delivery systems are moving ahead, and they don't want to be left behind. So these new digital natives who are physicians are going to evolve with that, and they're going to be your best ambassadors, and they're going to maybe be architects of innovation in the future. So let me tell you about Rubicon MD. My co-founders and I met about a year and a half, maybe 2 years ago, out of a MIT Hacking Medicine event. I was a mentor, walking around tables, helping people kind of think about the culture of healthcare. And Gil and Carlos were sitting there. And what they wanted to do was something very simple. They wanted to find a more efficient way to connect primary care or general physicians with specialists. And their initial idea was, traditional telemedicine, maybe using Skype, key opinion leaders, et cetera. But it's a very crowded space, and I don't think it's very different. I don't think it's very innovative. So we sat down, thought about it, and in the course of 2 hackathons, actually, came up with our current model. And I think it's a very radical model, and I'll present that for you. So Rubicon MD, we help primary care providers handle more specialty-related cases, right? We're not a patient-facing platform. We are a physician-facing platform. So we allow primary care physicians or general practitioners who may not have access to a specialist ask a very simple question and avoid unnecessary referrals. There's a study from out of UCSF and published in New England Journal of Medicine showing that up to 40% of specialist care is avoidable, right? So our platform is very simple. It redesigns that referral process, and it allows the specialist to give input at the point of care in a very simple way. So here's a video. Can we put the music up?
He's on his way to his local clinic to find out about a problem he's been having recently with nausea and vomiting. He's guessing he will eventually refer him to a specialist. Let's see.
Hello. I'm not feeling well today. I've been coughing blood. Do you think I should see a specialist?
I see. We are going to run a few tests on you and then consult with the specialist. Then I'll determine the best way to proceed and get back to you. I'm going to do a rapid consultation with a GI specialist using the Rubicon MD platform. Rubicon MD lets me share questions about a patient's case with a remote specialist. I send just the information they want to see, and I get a response quickly.
Rubicon MD optimization engine finds the best specialists to look at this case based on parameters such as availability, ratings, cost, and area of most of my downtime or whenever it is most convenient for me. Oh, this case seems like gastritis. If this patient walked into my office, I would recommend PPI medication. Let me share my ideas so the clinician can make an informed decision.
Excellent. I have received the diagnosis and proposed treatment from the specialist. Now I can do more for my patient. All right, Len, we have validated it with the specialist and there's no need for a referral at this point. I'm now very confident about the treatment I have in mind for you.
Wow, this is fantastic. I love having the convenience of my primary care clinic coupled with the expertise of top specialists. Thank you so much.
All right. So it's a little silly, but you get the point. And I think previous speakers had mentioned that I think we're in an era where patients are in charge of their healthcare, but it's also important to remember that physicians are still able to be kind of gatekeepers and help these patients understand their care better and get resources when they need resources. So the platform is designed to be very simple. Patient comes up with a rash. The primary care physician or the general practitioner knows that if they refer the patient to a dermatologist, it's going to take 3 months to get to that appointment. So all they do is they take a picture of that rash, write a quick little vignette, upload it on our platform, and through our algorithm, we send it out to one specialist, a dermatologist. They look at the case and they decide whether they want to accept it or decline it. Maybe they're declining it because they're going to a conference and they'll be busy, or maybe they're about to travel somewhere else. So if it gets declined, it goes to the next specialist who will decide to accept or decline. If the specialist accepts the case, they'll write a very quick little response, completely asynchronous, and that is routed back to the primary care physician. Now, the primary care physicians rates this response. If it's a good response, they'll give it 5 stars. If it's a bad response, they'll give it like 1 or 2 stars. If the specialist continues to have good responses, they get bumped up in the algorithm and get more traffic going this way, and therefore, they potentially would get paid more for more questions. It's a completely HIPAA compliant and anonymized platform. The general practitioner does not know who the specialist is, and the specialist does not know who the general practitioner is. This is not anything different than what physicians already do. Physicians love to talk to each other. I bump into colleagues in the hallways all the time, and they ask me, "Hey, Julien, I saw this patient with kidney stones the other day. This is what I did, blah, blah, blah. Should I do this and that?" And I don't know who the patient is, but I know the answer, so I'll give them a very quick answer. So we wanted to re-engineer this process, structure it better, and incentivize physicians to participate in this. So now specialists do what they used to do before, but they get paid a small amount of money for their knowledge, right? And primary care physicians, general practitioners who have a great relationship with that patient have an even better relationship with that patient now, because they've received knowledge from a well-trained specialist, share that knowledge with the patient. Patient feels comfortable with the response, and they avoid a trip to the ER, or they avoid a trip to the specialist that they've never met before. So there are 500,000 physicians and nurse practitioners in the US right now, about 1 billion annual visits, and surprisingly in the US, there are 26% more specialists than generalists. So they're sitting around sometimes. Some of them are doing research, but they could be tapped into to really participate in this network. So we've grown since a year and a half. We are now on both coasts. We are in multiple states. Our general practitioners are providing our service to a little bit over 100,000 patients. And we have 2 very interesting announcements that are going to be made in the near future. One is a partnership with a large academic medical center that will use our platform as a plug and play into their electronic medical record, and also an investment and partnership directly with an electronic medical record who is going to put us in front of about 50,000 primary care physicians in the US. Switching gear, talking about resilience, like what does it take to get to the next phase of your startup? And a lot of it is your ability to cope with change, and it's especially important as a physician. Speaking personally, for me, it was a very difficult decision to jump full ahead into a startup. I still practice because I truly believe in clinical practice and I care a lot about patient care. But I see a lot of physicians nowadays thinking about when is the best step to do that. Clearly, it's hard to do a startup if you don't commit to 100% or close to 100%. But at the same time, being a clinician gives you a certain perspective that is extremely helpful for the startup as well, and also gives you a certain kind of credibility if you're in the healthcare space. So my team, the three co-founders, Gil, Carlos, and I, started this a year and a half ago. Gil and Carlos from Harvard Business School. Gil had left his job a year prior with this idea, completely obsessed by it, and ran it. And when we met at Hacking Medicine, we really believed in this team. Carlos used to work at Telefónica in Spain, and also finished Harvard Business School. He was actually in his second year when we started the company, and I was on faculty at Harvard Medical School and a practicing nephrologist at the time. We closed our seed round. We got some amazing advisors and angel investors, including one of the co-founders of Skype. We have an advisor who is a physician and with 30 years of experience working in the healthcare insurance space. Used to run Florida Blue Cross Blue Shield, and other healthcare executives, also physicians who was a CMO at Henry Ford Healthcare System. So, foundership is important. That friction between deciding whether you want to continue pursuing medicine to a certain extent and jumping into entrepreneurship. There are a lot of parallels because as a physician, you are trained to be a leader. You are trained to have autonomy and to make important decisions that are truly important for your patient. And as an entrepreneur, you are doing the same thing. You have this mission, which hopefully is a socially acceptable mission. And if you're able to merge those two, the mission and your personal mission, then it's more likely that you're going to be personally successful and personally happy with your choice to go from being a physician to an entrepreneur. Very briefly, I just have 2 slides, and I have to talk about this for the take-home messages. But so Reno, which is a platform that I started when I was at Brigham and Women's Hospital, really was what I called a skunkworks lab or an X lab. It's a little lab where you're bringing people with a hacker mentality who just want to kind of disrupt things. And what we wanted to do is expose physicians to this mindset, help them with tools and resources to build MVPs. And so in the 4 months that the engineers were there, so I brought engineers from Paris actually, who were there for 4 months. And in the 4 months that we were there, we took on several projects with a time frame of about 2 to 3 weeks each time, really to build prototypes. And we've helped several teams win multiple competitions that earn them in total of $20,000. So it's a model that was really interesting, but unfortunately I wasn't able to continue because I joined Rubicon MD. And so we use the design thinking and the lean startup methodology as a framework for that platform. So to conclude, what are the lessons learned? I view this personal journey as a journey assessing intrapreneurship and what I call extrapreneurship. A lot of corporations, companies, but also if you think about it as academic medicine, want to innovate, but they want to innovate within that vertical, within their own company. When you're Facebook and Google, that may work because you can take some of your team members, give them some time to hack and create new features that can potentially add on to their to the company. But when you are in a hospital or an academic medical center, it's hard to build something internally and have it scale the same way, because you're really not building a product that you're scaling globally. You're taking care of patients within the hospital. And I see a lot of flaws with that format. And then extrapreneurship is if you are building a product in a vacuum, especially in healthcare, and thinking that just because you have a product, people will use it. It's really not true. You really need to partner up with an institution, with an academic medical center to run at least a pilot and see whether this is something that works at that institution, and then run a pilot at another institution, and then validate your product that way. And so this was a distinction between Reno and Rubicon MD. I had to leave the institution in order to run something like Rubicon MD. And then clinician innovators are everywhere. The past 30 years with science, we've seen a lot of physicians who are also scientists, and that worked, right? A lot of them were able to join industry with experience, but more and more we're going to see physicians who are interested in the digital health space, and it's not clear exactly how they're going to do that. And so I encourage people who are involved in ecosystems to really engage those physicians, teach them about entrepreneurship, the skills, the tools, and lower risk for them. And then finally, resources for clinician entrepreneurs. There's a lot to learn. There are a lot of parallels in the training to be a physician, but also, physicians tend to have big egos, and they need to kind of learn to forget that they're clinicians sometimes and build businesses, and they need a dose of reality about what it takes to build a business. And it's a journey, and one that I'm going through right now as we're speaking. And then finally, ecosystems for clinician entrepreneurs. I think it will be really exciting to cross-fertilize various ecosystems. The culture of medicine is different in each country with each language. Physicians in France, can be just as excited about innovation and startups, but they're doing things differently from clinicians in the UK and clinicians in Germany or clinicians in the US. But having them talk to each other, having the same kind of heuristics helps promote clinician entrepreneurship. And thank you for your time. Happy to take questions also if we have some time. Thank you.
Please stay on stage.
Okay.
So you're also not allowed to run away. And as I'm the one with the mic, I take my chance and put the first question.
Okay.
Rubicon is very exciting. I can say we can definitely use that in Germany. And the first thing that came to my mind was, how do you deal with it legal-wise? I know the Americans are a little bit crazy about medical errors. So who's responsible if somebody advises a general practitioner?
Yeah. So this is, like I mentioned, this is a behavior that already exists. In the US, we call this a curbside, right? It's one professional asking another professional for an opinion. There's no direct relationship between our specialist and the patient. If we decided to run a quick little A/B testing experiment, I could draft 2 cases, one real, one fake, send it to a specialist, and they would not be able to know which one is real, which one is fake. It's also a closed network where we bring in customers who are primary care physicians or general practitioners with the understanding that this is purely an information service. They can open a book, or they can go on an UpToDate or other resources to look for that information, but it's not filtered, right? Medicine is a lot more nuanced than that. And having that clinical experience, that ability to hone in into the exact question helps the primary care physician decide. And just based on an off-stage conversation I just had with Ronnie, I think he brought up a very good point in that it's the conversation sometime between 2 physicians does not lead to one solution. Sometimes it raises more questions, and being able to decide which path to take sometimes is the point of ambiguity for a primary care physician. So the primary care physician sometimes knows what they're going to do. They just need somebody to reassure them that they're going to do the right thing with a little bit of information. So from the legal aspect, we're working with a legal firm to define what constitutes a patient-physician relationship. And in this case, the patient-physician relationship only exists between the general practitioner and the patient. So any information that they get, they can use it in any way they want to take better care of their patient. Yeah.
Great, thanks.